Do we need to
We're now live.
these things?
Yes, we will do,
Yeah,
so that
because it's
the
being
remote.
Recording.
Yes. Yeah.
Right, good afternoon everybody and welcome to the December meeting of Joint Hosk. Before I start, I need to inform you the meeting is being live streamed and recorded. Item 1, we have 3 apologies, Kate Halliday, Louise Price and Lynn Corley. Item 2 is disclosable interest, so if anybody has a conflict, please shout out and we'll make a note of it, take the appropriate action. Item 3 is minutes of the previous meeting, which have been circulated. We're all happy that's thank you. Right, the main topics. Item 4, prevention, primary care, urgent and emergency care, discharge, task and finish group. Claire, you brought this to Shropshire Scrutiny last week, so to you.
Okay, thank you very much indeed, ladies and gentlemen, for allowing me to come here today. I'll give you a little bit of background because we've got some members from Telford here. There was a motion at full council earlier in the year about ambulance delays. So a task and finish group was formed. It was completely cross-party, so we had one from each party in the group. And almost as soon as we had our first meeting, we agreed that actually it wasn't about the ambulances at all, it was about the whole system. So we spent quite a lot of time, probably about a week, and Heather was on the group. And Kate were both on the group. Unfortunately, Kate's not here today, but Heather is. So the conclusion was that we needed a system-wide approach. And before I start, really, the first thing was I didn't want a 65-page report that sat on a shelf. I wanted a pretty live document. So my remit was really always one sheet of paper, which is what I've got this on here. But there's some key themes running through all this that I think are important to mention. And it's a shame that the NHS aren't here because I think they probably agree with the themes that I'm going to highlight before we start. So I think it's very wrong to apportion blame. We're not here to do that. We have to recognise the dedication of the NHS and social care staff. That's important. Recognise the public frustration, the mess we're in. Recognise the rural nature of Shropshire. And recognise there is no silver bullet. We all need to work together and the system has to be a system-wide approach, which is why, again, I'm disappointed that the NHS aren't here, or the lady who's dealing with this particular section. So what we did was we split it into 3 main areas, as Steve said in the title. So the first bit is, why do people go to A&E? So we looked at all sorts of things and, what about the primary care? What about the GPs, the dentists? How the unregistered patients go? In fact, if you listen to Radio Shropshire on Saturday, it was quite interesting because I think the hospital now are giving people a piece of paper when they actually arrive at A&E, asking them about their journey, asking them if they're registered with a doctor, why they've come, where they come from, all these kind of things, which I'd have thought should be in the system already. Because actually my job at the council, or as a councillor, is chair of performance management. So I love performance data. But anyway, somebody is doing something about that, because I think to understand the whole thing, we have to have the data sets at each particular juncture. So that's the first bit we focused on. The second bit is really based on the hospital and the infrastructure. So if you look at the infrastructure, is it in the right place? Have we got enough? So during the course of our investigations, we asked several questions of the ICS. Now, I don't know if this is true, but I have been quoted from other people that the World Health Organization says there should be 3 hospital beds per 1,000 people. According to the data, that very important stuff that I keep carping on about, I think we have 1.6 beds per 1,000, and that includes Shrewsbury. So, have we got enough beds? Have we got them in the right places? And that is really, really important. So that's the bit in the middle, really. And then the end bit really is about the discharge. So again, we've asked for data surrounding discharge. We were told at the Health Overview Scrutiny Committee that actually there is a discharge ward at the hospital now, which makes more sense. But I know one of the issues is somebody can be fit for discharge, so they're ready to go. However, before they're actually allowed to go, they've got to have the note off the doctor, they've got to have their medication, and they've got to have transport. Now, some of the data I've got, and I'm not going to put it out there because I want solutions, not arguments, but some of the data I've got is almost half the people who are fit for discharge in a day don't get discharged because of all these other factors. So I think it's important, again, that we have this data and we stop arguing amongst ourselves and actually come up with some actions. So what I'd like to say to the NHS, I appreciate they're not here, is I would absolutely be more than willing to have a meeting with them, with Rachel, and go through this and actually talk about some of the actions. But as I say, I think, we could talk all day about all these actions, but without the NHS person here, I think it's going to be very difficult. And I think we need to understand, how they are going to formulate their action plan across the whole system. That's really the crux of the matter. Anyway, thank you. I'll be quiet now, but if anybody's got any questions, then I'm more than happy to answer them, and Heather's probably just as capable of me as answering them. Right, thank you.
Thank you, Claire. I think we're all frustrated with the same challenges and have been for some time. Opening up to the floor anyway. Heather, go on, Richard.
Yeah, go on.
Can I just add that actually we did look at social care, and social care is part of adult social, all social care.
Yeah.
Is a fundamental part of the whole picture.
Yeah. Yeah.
And that's for both Telford and Wrekin and for us. And we all have problems around recruitment, retention, but actually just delivering the packages. And there's no point in giving people a package because we have a number of people with packages that can't come out of hospital, including one of our counsellors who couldn't come out of hospital because they couldn't find people to deliver the package. So, and that's a nationwide issue. Some places it's slightly better than others, but actually it is a fundamental part of this picture.
Can I?
No.
Yeah. Sorry, Steve. Yeah, I didn't want to single out any particular part, because I think that's unfair without the NHS here. Because I do think we need to look at the whole picture. There's things that we can do, that the NHS and social care can do, to hopefully prevent a lot of people actually going to A&E. So I think there's pressures, going to A&E, coming out of A&E, and actually in the hospitals. And I don't think you can prioritise one over the other. It has to be a whole system approach. I know as a country we're struggling for nurses, we're struggling for doctors, we're struggling for healthcare workers. We're struggling for the people to actually help us solve this. But I do honestly feel that part of this problem is we've got some very, very talented and good people working for us in all these different departments. But we do need to look at the system. The system needs altering, because I think there could be things we could do within the system to make things better. And that's what I want them to focus on, because we have to make, or the ICS has to make some changes fairly quickly because, you know, we've got all the winter pressures. So we have to start doing things now, not talk about it for another 3 or 4 months. We actually have to start doing stuff now. And so I want us to cooperate and work together doing that.
Hillary.
You probably just partially answered my question, actually, with that. I thought it was an excellent piece of work, and some of the stuff that you brought up, I think, was really, really good. I struggle a bit with the recommendations, but you have partly answered that in that they are huge. I mean, I sat on task forces 10 years ago looking at data sharing and IT systems, and, you know, what's changed in that time, you know, and it just fills me with dread that you're going to start that whole huge thing again. Evaluation of current and future needs in different communities, again, a huge piece of work. I'm not saying it doesn't need doing. It's just that we're in the mire now, and just think there must be some quick wins.
Yeah. Can I come back? And I agree with you entirely. And I think this is why I'm frustrated that the NHS aren't here, because I think there are some data sets. I agree, you know, if we do them all, it's going to be horrendous. I think there are some data sets that we could focus on that would make a real difference. So, for instance, Saturday they were talking on the radio about filling in the forms as to why people go in there. What, you know, I know from the work we did, quite a few people don't register, so they haven't got a doctor. I don't know what percentage that is, but there'll be a percentage of people who haven't got a doctor, so they just go straight to A&E. So we need to understand some of these things, and I certainly think the information they're gathering as people go to A&E, you could almost take a week's worth of that, and you could understand what's actually going on.
Yeah.
So I'm not saying doing the whole bit, but there are specific data sets that are going to help you.
Derek, what do you know?
Yeah, I understand where you're coming from, Claire.
Yeah.
It's something we've been struggling with now for ever since I've been in the committee, and I was one of the founder members of the Joint HOSC 14 years or something in that region. We've been talking about the same thing, changes that will make our NHS work. Now, when I first heard of the ICS, it was great. We've actually got something that can actually, a system that can actually make it work. And quite frankly, they're struggling as much as anyone else. There's lots of policies coming up, lots of plans. Not that they're sharing it with us at the present moment, but we will expect that to happen, because quite frankly, that's what we're here for. And the reality is, every part of the system has to work together. And it is the most important aspect of this. Now, there's lots of talk about one system, you know, will solve this, but by solving that, you create a problem somewhere else.
Yeah.
And that, you know, you end up, and everybody seems to be willing to not so much talk about it, but actually contribute to it and do something positive about it is a very different matter. And you end up with a system that everybody's chucking it and passing on the blame, passing on the punter, and they end up, there's no way there, because we need a proper exit strategy. We need a proper entrance strategy. We need a primary care that works. We need an ambulance service that is able to get people there in time, not 9-hour waits and then another 5-10 hours sitting in an ambulance later on. We need to actually have all the systems, and that's what the ICS should be there for. And that's why we've got you here. That's why they're here today. But we've been trying to talk to them now for some considerable time to make sure that what we would like to see happen, or at least let them tell us how it's going to happen, when it's going to achieve, when it's going to start producing the amount. All we see now is a system that seems to be entirely broken down. There's a lot of talking, but we need, as you rightly say, we need to see action.
Doug.
Yeah, very similar comment, really. But I mean, we are victims, as we all know, of a national breakdown of a whole range of things. But clearly, this element comes very much within what we're talking about as the next agenda item, which is the ICS interim strategy. So we need to look at that alongside other things. Who would be in the feet of the ICS and the shoes of the ICS at the moment, with everything that's going on around? I have to say, I'm in despair sometimes of how locally, what on earth we think we can do to change what is a fundamental national problem, and national problem of poor planning, lack of fund, lack of resources, lack of capital money, lack of manpower planning. All those issues all contribute to the position that Claire has outlined, one of the elements of the problem we got. As I say, I'm glad I'm not in the shoes of the ICS at the moment of how you deal with this, but we do have to recognise that these are realities, and anything we can do to help. Public information, I guess, is one of the things we can do, and maybe we'll discuss that in the context of the next item.
I think they are all kind of wrapped in together. Before I come to David, just going to ask Nicky if you wanted to comment, seeing there's been a lot of ICS.
There is, thank you. And yes, I mean, you're quite right. I'm conscious that my colleagues leading on that are not here today, and I apologise for that. Had I known in advance, I could have probably got a little bit of briefing from them. So whilst I'm not acutely working on this piece of work, it has been a big part of my professional life for a long time, and a big part of work that I was doing when I was in Australia. I'll share a bit of information about a piece of work that's going on, which I think is quite key to this. And you may have touched on some of this, Claire, with the issue about the questions and so on that you've seen. We are undertaking, under my leadership bit from the strategy development, we're undertaking what is a full system utilisation review at the moment of all of our beds. Acute beds, community beds, how that touches into community, and it will roll forward to kind of have a look at some of our social care and population health at the moment as well. What that review is doing, and it's called MCAP, which stands for Managing Care Appropriately for Patients. And it's interesting that when we've talked about, are the beds in the right place, these issues about patients coming in without a GP, how that discharge process works is a little like eating the elephant, isn't it? There is a lot in there. But one of the things that review is seeking to do is point out how we are currently, if you like, operationalising our business. So how do things actually currently work? But within the evidence-based tool, we'll be looking at exactly that. Have we got the beds in the right place? How much of this activity, ideally, should we shift to here? How many patients are coming in for this particular reason that ideally could be dealt with elsewhere? Now, some of that we feel we know intuitively, but what tends to happen is historically a lot of our systems don't connect very well. So data systems in primary care, data systems in the hospital, data systems in social care, they're not all on a shared platform that makes it very easy to look at as one big piece, as one system piece. And what tends to happen is we start trying to glue things together to make this Frankenstein's monster of breaking that down. So the idea of this review is one data set, one time, in real time, across all beds over a period of weeks, strong snapshot for how things are working. What I will be doing then, although I'm not part of this working group, is I will be supporting them in helping to compartmentalise some strategic pieces for them to work on with some evidence, with some data, so they can start, if you like, to start routing some programmes of work through this, because otherwise, as you rightly say, this is such a big issue. It's just really like trying to eat the elephant. So that review actually concludes today. It will take us about a couple of weeks, I think, as we come back into the new year to get that first high-level data assessment. But we've got a big piece of co-design work planned from them that will be bringing everybody to the table from across all bits of the system to look at what that mapping is showing us and to start to see if we can design some of those solutions together based on some stronger evidence of exactly what's happening in our system and why. So hopefully in the new year, perhaps along with this piece of work, we can share some sort of further detail about where we're going with that.
I think that'd be useful because I think going forward, we don't want to lose Claire's piece of work, and we want to, as a committee, we want to work with you, not against you.
Yeah.
So I think January we will be sort of forming and shaping our lines of interrogation, if you like. So if there's an opportunity to come back and at a further meeting, probably an online informal meeting, not a public meeting, just start interrogating some of that and work with you. I think that would be useful. David.
Yeah, going back to what Doug said, basically the health service is in a real bad state nationally. What really upsets me, because it shouldn't be happening, is the performance in Shropshire is at the bottom end of all the metrics. We're performing worse, but we've got some really healthy people living in Shropshire. We haven't got a lot of the rubbish that other authorities have in terms of deprivation. I know we have deprivation, but we haven't got the quantity of it similar to other areas that are doing better than us. And that's what I think a lot of people want to know. Why are we at the bottom when other similar communities are, performing much better? And the answer to that is because basically resources are wasted in large quantities and everybody pays the price. In terms of data, there is a piece of data, it's about 2 years old now, which shows how many people turned up at A&E, both A&Es, combined figures, and how many left A&E, not being referred to a GP, not being referred on to somebody else, and it's roughly, I think, about 33% of people that go in there, something happens to them, but whatever it is, there's no need for any more to happen. That's what the data, it's 30%. That is a big number because the volumes going through from memory are something like, do you know what the volumes going through A&E are? I can't remember.
Not off the top of my head.
I think it might be, let's say, 135 to 140,000 a year minimum. So 30% of a big number is a big issue. But that, now I will speak up for my colleagues in South. They're doing this research, obviously, to find out why are people presenting. I suspect they're doing that research because they aren't, as an organisation, they're not in much of a position to do much about it. The A&E is the last line of defence for every citizen in this county. You're absolutely bomb-proof to see a doctor or a nurse if you turn up. Everybody knows that. Yeah. And if you're having difficulties getting a hold of a medical opinion, you're going to go. And you're quite right to go because you paid up front for it anyway. You bought it, so why not use it? That would be the attitude I would have. So that from the hospital's point of view, I can understand why they're asking these questions. It's so that they can generate the necessary data in order to inform strategic changes elsewhere in the system. But as the hospital are often victims of excess demand. Having said that and stood up for them, I will now tell you they waste resources like nobody's business. Thank you, Chairman.
I'm really interested, I'm really pleased to see that they're actually going to get some up-to-date information. I think that old information also included a number of people who turn up to wait for some considerable time and then go home again without actually being seen. So there's a whole piece of work around those and so on, but they will obviously be picked up by that review. My concern is that the review, and you did say the review will be through in the new year, a couple of weeks into the new year. It's what we do with that, and how quickly we do something with it, because actually we're in the winter period, and we've already, I'm afraid, seen winter planning, which we weren't terribly impressed with. And unless we've actually got something to move to shift things in the near future, we will go through another winter without any changes at all, with a ward that probably that is going to be put in place that we have no idea how it's going to be staffed. So there are a whole raft of things that actually we do need to see, and that data coming through would be really useful for it to come back to us to inform all the work that we have done, not just Claire.
No.
It's because it was a real eye opener for us. We knew that these things were all part of it. We just proved it.
Yeah.
And that's why it's so valuable, that piece of work. So the review is important, but only important if we act on it quickly. And I would like to see some sort of timeline for that. And I know it's not your piece of work and so on, but it is important for us. I'm also really concerned when we start talking about have we got beds in the right place? Because as soon as we do that, we shift away from rural areas. We say, oh, there aren't many people there, so we can't deliver anything there. And we centralise stuff. And what happens when you centralise, it makes it really inaccessible. And you come here to talk to us about the ICS, which does talk about access. I have read it. But actually, if we just do it on numbers, population numbers, you will actually not deliver for the rural parts of Telford and Wrekin, who they do refer to in the document, or the rural, very large rural areas of Shropshire. And I'm really, really going to follow what the fuller recommendations were about those rural areas. So there was some alarm when you started talking about are the beds in the right place.
Well, if I can I just respond to that? So beds in the right place, I think, is that whole continuum. So even if we start within the hospital system, what these types of reviews will typically show us is that we potentially have patients in ICU, for example, who no longer need to be in ICU. They need to step down, and so on and so forth, right the way through the system, because the acuity needs to move. But as we get into complexity with patient flow, with blockage, with discharge, we end up with patients in the wrong places, which make the whole thing even more glued up. But beds in this context as well, I think it's important to understand that the bed is not always necessarily in a building. And I think one of the things we really, really need to understand is the kind of that non-facility bedded element as well in some of our community beds, in some of our rural areas. And how do we not necessarily just offer more in that shift to the left, but are we doing the right things? Could we do different things? Where do our models of care come into that? So I think it's looking at beds through the whole spectrum, not just in terms of a hospital.
I suspected you would say that, but we need the clarity, and we need to have that absolutely upfront, because it's really important.
Yes,
really
we need to
and
see
it hasn't
numbers
been delivered.
against it.
And in a conversation I had recently with communications from the ICS, in fact it was last week, I was actually told we probably can't afford any of that.
Right.
Okay.
Yeah. All I was going to say was when we did the task and finish group, we had a lot of we had one from each group, but we had some very experienced counsellors on it who understand their communities and understand the concerns of the communities. And I think it's really important that when we do all this stuff, it should actually be I don't know how you talk about it, maybe a little committee or a little group. But it'd be really helpful if you had maybe, when you were discussing people going in, if you had a nurse from A&E there, perhaps, a couple of counsellors or something, so they can actually represent the views of the public. Because I think one of the frustrations for people is the decisions have been made by managers who aren't necessarily that close to the customers, you know, or the actual situation that's going on in the hospital. So I think you do need checks and balances, and I think that would be a really good check and balance, because you'd have some practical ideas, and I think it would keep your aspirations grounded. Thank you.
Sorry. I think actually David said it very much in the early part of his speech. It was basically saying that the research was done 2 years ago, and the data was providing 30 to 50,000 people were visiting the A&Es, possibly unnecessary. What's happened? What has it been done with that piece of information? Is this just another information gathering session where nothing is going to happen? Because quite frankly, if you've got that information saying, look, we've got 40,000 people on average visiting A&E, and I'm not saying nothing's happening to them, they may have be a minor injury or whatever, but they could possibly have been treated elsewhere in the health care system. Why is nothing being done about it? Because we've all been chuntering on and moaning on about the lengths of queues in the A&Es and the times the waiting times have extended, and the fact that it's messing up the ambulance service. The whole thing is being messed up with it. Why haven't we started finding ways of treating these people locally without clogging up the system? And it hasn't happened. And quite frankly, we should, we don't want just information gathering to lie there and have the long thing of saying we've got a couple of weeks, 3 weeks, but we need action to prevent it.
Need more GPs.
Yeah.
Yes, better money invested into primary care.
Yeah.
Well, just on that note, really, and I'm recycling old things, but they're still not happening. Farmer knocked on my door the other day and said, I know you're something to do with health. Can you just go and say that my wife was in hospital over the May Day bank holiday, had to discharge herself because there was nobody. It was the May Day bank holiday, there wasn't a doctor there to discharge her. The person in the next bed couldn't go home because the pharmacy wasn't open.
Yep.
I mean, for heaven's sake, how many times have we sat here and talked about that?
24/7 care. Yeah.
Yeah, and it's still over. I've only been on this board, 4 years, but it's happened time and time and time again. We've said that, and it is still not happening. Why not? I just find it so frustrating to get stories like that still.
Yeah.
And we know the problem. You don't need a survey to tell you that's a problem. We know it is.
Coming back to the figure I just quoted about 30%,
Yeah.
if you like, no further action types, yeah? Compared to other parts of the country, we're about 10, 12% higher than everybody else. Now, that may be something to do with rurality. I haven't drilled down on why.
Right, yeah.
It may be something to do with rurality, because as I already said, it's a bomb-proof bet that you'll see a doctor if you go to A&E. If you're stuck out in Clungumford, maybe that's the bet you want to place. I don't know.
Yeah, I think it's right.
Okay, so we've got lots of things to consider there. I think the
Sorry,
one thing
Chair.
I would like to ask is that if, Nicola, if your colleagues are doing that data gathering, if that could be, it's you that's doing it, if that could be shared with us as a committee, because I think we want to be doing some
further work on this. Have you got a plan of a timeline, Tom? David needs to come back to
Just
the
one point, and on your recommendations, number 4, it's about health literacy, something I hold very dear to my heart. In actual fact, if you stay for the next presentation, you'll find that health literacy is part and parcel of the strategic plan. So they've got that one tied down in the policy.
Okay, thank you.
Tom. Okay, so in terms of, I guess, next steps with this, so we did shortly before the meeting get the apologies from Sam Tilley, who would have been attending for this item, but I think unsurprisingly, there are pressures in the system
Yeah.
that are taking exams time. What Sam's highlighted is we sent through the task and finish group a lot of questions to be followed up on. Sam has asked that this committee, the Joint Health Scrutiny Committee, whether it's in this forum or as the chair said in an online, offline meeting or briefing session, that they're able to come back in, bring more partners in from the system, so the ambulance service, mental health, others, work through those questions in more detail. I think pick up what Nicola's identified as well as the sort of updated view on understanding what's happening, where the demand is, bring that in. One of the things that the Task and Finish group were clear on from the start was that it was a very live situation, live environment, that the challenges to the ambulance service, the challenges to A&E, the challenges to the wider system and social care were not sort of standing, waiting, and then the Task Group would report back. They recognised that a lot was happening and a lot was taking place. So, you know, as David's just said there, health literacy is going to be something which comes up. It was something that was identified by the committee. It was identified as, the Task and Finish group, it was identified as something both in terms of communities attending A&E when maybe they didn't need to, but also where the options are in terms of primary care and places you can get that support and service as well. So it's probably good for the Task Group to hear this progress. I think that if I paraphrase what they said in the meetings and what Heather's just said now, it's kind of, we've seen it, we identify it, we know things are happening. Is it making a difference? And can we be reassured that it's making that difference going forward? So next steps in the new year, and I think for this committee is a chance to have a conversation when it comes to the work programming item later on the agenda, to think about how you might want to scope it, to give those members from Telford and Wrekin and the co-opted members the opportunity to look through the report a bit further if they need to, but also think about any particular lines of inquiry or questions that they want to cover as this committee as well. We can reshare those with Sam and other colleagues, and then we can look at getting those meetings in place into the new year. In terms of a timeline, when we think about urgent and emergency care, when we think about strategy development that Nick is leading on, when we think about the timescales that you've previously been informed about when it comes to the review of the winter planning, when the winter planning starts, if the committee agreed, I think it would be useful for you to have held your online briefings and be targeting coming back to the committee meeting and inviting the relevant partners from within the system and being mindful. I think it's Telford and Wrekin Council's elections this spring, is maybe sort of July time, looking to have a meeting of this committee, whether it's slightly extended beyond a 2-hour meeting, but it's an opportunity to bring your questions from your online work and preparation and invite the partner from the system into the meeting in this public forum for you to do your area of focus, and ideally, timing wise, inform the next set of planning for the winter plans and ongoing, what your expectations are and what you'd like to see as a committee going forward. So hopefully that summarises.
Thank you, Tom. Certainly, endorse that as a plan. This is doesn't matter which section we are looking at, whether it's the piece of work that Claire's done or the ICS, which we're going to hear about next, or the winter plan. It all dovetails together because it's so integral to each other. So I'll endorse that. Doug.
Just one more thing to throw into the pot, which is the difference in performances of local practices. Some are performing fairly well in terms of access to appointments, some aren't. And I wonder whether, when the work that's done at the hospital end, if they're able to identify those practice areas which are more represented or more highly represented than others, and there might be a factor there. I know it's difficult because every practice is different, they're independent, but we need also some conformity. We need to get some of the GP practices at the lower level operating at the standard of the higher level, and that is one thing. I don't know if we've looked at that recently. I remember looking at that some years ago, the different performance of GP practices, but I think that's another thing that needs to be put it into the pot.
going back to data again. Nicola, go on.
I can just clarify on that point. So in January, our integrated care board performance process will start to capture and report on access in primary care with general practice. So up until now, it's not been included in that data set, but from January it will be. So
It might be a factor of the number of patients per GP. It might be something else.
We'll factor weighting times, appointments, etc.
Got Heather, Eric and David.
Could I just remind you that there are a significant number of Shropshire patients who are registered with GPs in Wales. And when we come to the ICS, I should raise some of that because it is quite important. And for them, we don't want them going to A&E either. In my experience, locally, my Welsh GP has a better reputation than my English GP in my division. But it's worth looking at that as well.
That's identifiable information, that is.
Yeah. I've got several practices that actually supply my division.
I just need to ask the question really regarding the survey. And you're saying that that information will come to the board. But where did you get the information from? Did you get it from the doctors, the surgeries, or are you getting it from the patients? Because I'm quite sure the patient's view is far different from those people. And the amount of patients who have just given up because they can't get through on the phone, they can't talk to them, they go to the reception and they're told, look, go home, make a phone call, and then go, and they don't get through. Because there's a huge amount of people who wanted or tried to talk to the doctor but couldn't do. So where is the information regarding access coming from?
Well, it's coming from general practice. So
it's coming from the doctors.
Yeah. So you raise a good point in terms of pulling that data from general practice systems. There's another bit of work and a conversation to have, isn't there? In terms of that big piece I mentioned, the MCAP review, that information is it's a real-time study with the clinicians working through the medical records, interviewing the patients that are sitting in front of them. So that is quite a robust process of full access to all the clinical information and what's happening with that patient, as well as an interview with them. But I do take your point around the primary care point. I can discuss that with Sam and colleagues.
And will you triangulate that with Healthwatch Shropshire? Because I know they've been actually gathering quite a lot of data on that. We don't have Lynn with us today.
Yes, I'm working quite closely with Lynn on a few things.
David?
Quite a few years ago, I used to interrogate the QOF data. I still do. And the QOF data used to indicate how many patients from a particular practice went to A&E.
Can I just say quality outcomes framework, please?
Yes. And it's a wonderful document.
Just explain what you mean.
It helps you go to sleep at night. Anyway, the point being is that it's quite surprising which practices have more people or less people turning up at A&E. And there's a pattern, and the pattern goes on and on and on. And it always struck me as being a piece of information that I would have acted on, because I would have probably, as chief exec, gone and made a visit to a few GP practices and read the Riot Act, quite frank, because they were over consuming resources. And I would want to know why that is. Now, I ask you, is that part of the reports that are going in January saying these practices had 10 per thousand A&E attendances, this practice down here had 100 per thousand? Are you going to that level of detail?
Yes, I'll say two things. Without the risk of being shot down in flames here, I was a co-author of QOF back in the day. So that probably might get me shot. So two things here, I think. One is that and primary care does not sit within my portfolio currently, but what I would say is I think within our primary care development activities, that should definitely be happening, and I'll pick that up with Claire and team. So I think the focus has not been as strongly on primary care as far as it probably should have been. The burning platform has been the front door, and I think we need to start moving away from that. And I think we all know and we all sense that. The data that I'm talking about is really core performance data on activity, wait times, waitings, how long are people waiting for appointments. So it's top level stuff. But obviously, as that data is escalated through our various committees and governance processes, it is going to raise questions. So I think it will strengthen some of the focus that we've lacked on that so far and direct people back into areas like the primary care development agenda, where we should be looking at exactly that. I agree with you. So I will follow up on that with.
Well, I think that is a crucial piece of information. Where are the A&Es coming from, being referred from?
Yeah.
And then we can see, and we will see a pattern, because I've seen it.
We will, and we'll see that pattern in the NCAP review as well.
Thank you.
Okay, I think we've probably done that one to death. I think we've got a plan of action now which Tom's outlined, and there's a few actions from several people in the room. So, sorry. So I think we've dealt with the recommendations. So, leaving to thank Claire for the sharing that committee, and we will be seeking your further assistance, no doubt.
Thank you. Thanks, Steve. Happy Christmas, everyone.
Okay. And with that, we'll move on to what you've been touched on already, I think, but integrating care strategies. Nicola, over to you.
Thank you. I think I'm going to kick off, but I'm going to have some assistance from Liz, and I think Rachel Robinson is planning to attend, but she's double booked today, so she'll be along as soon as she can. The first thing I think, as a point of clarification, I should say, is that this is the paper and information that we're taking to the Integrated Care Partnership meeting later this week. So when you look at the recommendations and the information in the cover sheet, just be aware it's being prepared for the ICP, and we've taken the opportunity, being it's all happening this week, and we've got joint hosts this week, to I won't say cram in, but to try and make sure that we've got the opportunity before Christmas to share this document. So we've taken a liberty of pulling that here as well. The first thing to say, I guess, we mentioned that the national guidelines at the moment are frantic, to say the least. The lots of things happening, and it's going to be an interesting week, because much of the guidance we're still waiting for around some of the next steps and how we get into the planning detail are due to be released on the 23rd of December. So we're kind of anxiously waiting that this week to kind of get a better understanding of where we move from interim through to some of those next steps. So this is an interim integrated care strategy. And the challenge, I guess, for the first year, given that this is a short year in the first year for the integrated care system, was we had two options. If we were ready to run with a full singing, dancing, perfect integrated care strategy, then no problem. But many systems, including us, have determined that we will run with an interim version, and that is to consolidate the work that we know has already been happening across our two health and wellbeing boards, been working quite closely also with our two Health Watch organisations to bring together what we understand so far, the what of our system. What is it that we see as the big challenges, the big issues? And this is going to form an important part of the next step of the Integrated Care Board writing its strategy for the next 5 years. In terms of how this was pulled together, I think it's good to know that the Integrated Care Partnership had its first meeting in October. So a little late compared to some systems getting the partnership up and running. That's put us on a really, really tight timeline between October and December to consolidate this work, and kudos to our two population health leads for working like crazy in the background with the health and wellbeing boards to bring this together. But that said, we have had, in agreement with the ICP, a working group that's been sitting below this to sense check, to look at where the consultation, where the engagements happened so far, sense checking some of the information. Health Watch have been part of that, both for Shropshire and Telford and Wrekin. And so there has been some legwork behind the scenes on this. I think that's important to say. We did also, in agreement with ICP, have a stakeholder event in November, knowing that the next ICP would need to meet in December. So again, we had some opportunity, even as a consolidated document with what we've talked about so far, to show the priorities, the major challenges that we face. Together with a group of stakeholders. And that event happened a few weeks ago, back in November in Telford. We had just over 40 people in the room for some very interesting tabletop discussions based around these priorities and some of these issues. And the feedback that we've had from that will also be going to the ICP meeting later this week to give them a flavour of how, I guess, the priorities in there so far have been viewed, as will, of course, feedback from discussion today. If we can move, to page 14, or I think it might be 19 in the numbers down the side. Excuse me for the different numberings. That's it. Thank you. Thank you, Amanda. There has been a lot of discussion, I guess, in conversations about why will it be different this time. If we've done reviews before, if we understand some of the problems from before, why have we not managed to get that momentum? You know, what is it that's happening? And I think for us as an ICS, and understanding that we do now have some additional opportunities, if you like, with the new Health and Social Care Act, how we bring together our funding, our commissioning, a big focus for me going forward in the building the strategy. You know, how will it look? How will it be different? And this was a section that was very important to the work group back in November. And you'll see on there the kind of themes that came out of that. A key focus on being different, being around people first, a strong focus on prevention and inequalities, and we've touched on that today. The subsidiarity issue being very key, getting into rural issues, not having one strategy, one set of priorities that necessarily fits all if we're going to get into the inequalities agenda. That the joint working does mean that we get into that conversation of what do we do about joint funding, collaboration, commissioning differently, rather than just collaborating as we have before. How do we truly tap into those health and social care changes? Empowerment was another big theme that people wanted to see moving forward. How do we strengthen local communities to have a voice, to be stronger in terms of self-care, to know how to help themselves, how to seek out advice and information, and obviously a key issue about the innovation, evidence and research, acknowledging that if we do want to work differently, if we do want to see it as differently this time, it's not all about goodwill and information, but we've got to be a bit more creative. We've got to work on evidence. We've got to get outside the box in some of our thinking. I'll hand over, I think, at this point. Oh, awesome timing for Rachel coming into the room. We'll give her a sense to sit down. But I think Liz will kind of move us on to, is it slide 14? Slide 14, to start to understand, I guess, how we've consolidated in this interim document some of the work that's already happened with two of our health and wellbeing boards.
I can't see the numbers.
Yeah, just keep going.
Keep going. Stop.
Keep going.
That's it. Thank you.
Thank you. This one?
Yes.
Yeah,
thank
thank
you.
you.
We need to press these, don't we? Yes. Okay. So, as Nicola's described, this is it's an interim and it's a draft strategy. And what we've done is to look at the existing health and wellbeing strategies for both Shropshire and Telford and Wrekin, to understand what Health Watch in both areas has been saying, to understand what our clinical stakeholders have said in terms of a clinical multi-professional group, and also in terms of what this joint task has said in recent years in terms of priorities. So what we have drawn together, therefore, is, and we try and keep it simple because we like simplicity to start, is to have a set of priorities across these headings in terms of population health, health inequalities, and health and care priorities. So these should be familiar priorities to both health and wellbeing boards. When we met in October at that first partnership, and Rachel presented what the Shropshire Health and Wellbeing Strategy was, and I similarly did the same for our draft Health and Wellbeing Strategy in Telford and Wrekin, the partners around the table could see those similarities. So in terms of population health, their start in life is absolutely crucial for population health and for inequalities. And we think it's an agenda that gets missed in terms of the ICS and the ICB, but perhaps in terms of its focus. Unhealthy weight, both areas of high levels of unhealthy weight is probably the key risk factor for the population. Mental well-being and mental health is key in terms of improving health. Preventable conditions, particularly heart disease and cancer. So Telford and Wrekin have high rates of preventable mortality for heart disease and cancer, but equally heart disease and cancer mortality and preventable mortality is what's driving the life expectancy gap in both Shropshire and Telford and Wrekin. So it's important for both areas. And then, and Rachel and I were actually at a partnership earlier today around drugs and alcohol, but in terms of the impact of drugs and alcohol and domestic abuse on our communities, we felt that was another important and comes from both health and wellbeing strategies. In terms of inequalities, a focus on the wider determinants of health. I think everybody understands that 80 to 90% of the determinants of health lie outside of the NHS, and so we need to focus on those. And the two key areas we felt was cost of living and homelessness, but obviously there's a wide range of other wider determinants that we could focus on. But importantly, there is also inequity in access to preventative healthcare within Shropshire, Telford and Wrekin in terms of cancer screening, early diagnosis, health checks, vaccinations. We've heard of the great work of Bob and Betty during the last, this time last year, I think. So I'm having a little bit of a Omicron moment now. It was literally just before Christmas, wasn't it, that we launched. But that's an example of actually removing some of the barriers to the uptake of people taking up preventative healthcare, and we need to do more of that. So there's some examples. And in terms of the focus should be on the 20% most deprived areas. I know that will focus particularly on Telford and Wrekin, but also draw in that rural excluded population, particularly in Shropshire, but equally have pockets of that in Telford and Wrekin and other excluded groups as well. And then for health and care priorities, it is that really that proactive, preventative approach, holistic care, focused within communities that we wanted to have that focus on. But equally, drawing upon the discussion earlier, primary care access and urgent and emergency care access in terms of, you know, the topic of conversation, the here and now topics of conversation around this table and in many communities in Shropshire, Telford and Wrekin. And then lastly, there's a slight error in terms of clinical priorities. They are MSK, which is musculoskeletal disease. It isn't respiratory, it's diabetes, cancer, heart disease, mental health, and again, urgent care, urgent and emergency care. So actually very similar to some of the priorities we've already put as part of population health and health inequalities, but we wanted to capture it very simply in a slide for everyone to see. Rachel, I don't know whether you wanted to.
Firstly, just say apologies, Chair, for joining late. I think you've summarised very well. I mean, these are the key priorities that is drawn from the evidence which is provided within the strategy, based on the information that we've already had through our GSNAs, through our health and wellbeing strategies, through our consultation, through Health Watch, through the clinical conversations, and through the work of this board. And this is pulling it together. This is the what we need to be doing. What we need to be, not the how we're going to do it, but this is the what we need to focus on to improve the health and wellbeing of our population, and our system need to focus on jointly. And I think, you know, for us, there's some areas in there which, as you said, have come through very strongly in our health and wellbeing strategies and the work we're doing. But I think for the Shropshire system as well, to draw out that rural exclusion, which is important, and again build on that inequity and some of the learning, as you said, there's from COVID that we all are trying
to forget,
yeah,
but remember.
Yeah, the learning is really important. Thank you.
I think, Nicola, you're going to do next steps.
Yes,
which is right to the end of the document.
It is. If we can just run right the way through to those last couple of, thank you. Thanks, Amanda. You're already on it. So I guess a big bit of what happens next is the consultation and engagement. So part of the challenge that I have now in the ICB is developing our 5-year forward plan. So they've actually settled now on the term, just to be clear, because we've heard lots of language about this, haven't we? The joint forward plan. It's a 5-year joint forward plan, or JFP. You'll see it referred to. And this is the guidance that will come out on the 23rd of December. Our understanding is it will be it'll be a fairly templated document. In other words, obviously NHS England are keeping a fairly close sense on how they want this document templated, structured, and so on, as is often the case. So I'll be keen to get my hands on that. Yeah, given that this is an interim document, we do need to now move to think about how we make sure this very strongly feeds into and influences that 5-year joint forward plan now. So running from January through to March, there will be quite a broad, deep consultation and engagement programme that will be put in place, and we'll be presenting and talking to that at the Integrated Care Partnership this week as well. And that will pull a number of things together. Absolutely, the interim integrated care strategy. What have we learned in terms of particularly population health inequalities? What do we know we have to address? We'll also be looking at the clinical strategy, those 6 priorities that Liz referred to. We will, of course, need to get our heads around sort of our available budgets, you know, where we are with what we have to play with. And from kind of pulling all these things together within our engagement process between now and March, we're going to have to draft what will be, again, the interim 5-year joint forward plan. There's a lot of interim, isn't there? There's a lot of interim documents, which kind of adds to somewhat of perhaps the confusion or mystique around that. And I think that has come about because it is a short, tight year within which to kind of get a lot of this done and done well with adequate consultation, and to make sure that it is an authentic process. So whilst we will end up with 2 interim documents at the end of March, an interim ICS document that you're seeing, an interim forward view plan, there is going to be a rolling annual refresh process. So engagement, consultation will continue. We will get a stronger sense, I think, fairly early in the spring as to what the first year or 2 years of the plan will look like, but we will be continuing with that engagement and consultation process on that bigger 5-year piece once we see what's in the headlines on the 23rd of December from NHSE. I suspect it's probably a good place to stop and perhaps get into some of the detail, or I'm assuming everybody has read the document and everybody's really keen on some questions and discussions.
Yes, a good call. I knew there were going to be a few hands popping up. I think, Derek, you were first out to start in the box.
It's very clear, one area that seems to be missing here is good housing. and that is the fact that we have got in Telford in particular an ever rising amount of HMOs, which offers very poor housing. It offers unsafe. Without the basics of a good house and a good place to live, then the health targets are really, you can throw them out the window, because it's a huge area where the health starts. And also the worry and the stress and everything else that goes with poor landlords. And I know that we are struggling like hell to actually deal with those landlords because of the extremely difficult legal system that we've got, where landlords can change their name and you have to start the process all over again. So housing to me should be in there. The question I have to ask really about the whole strategy is, because it is an integrated care strategy, is about, there's an awful lot in there, and a lot of it depends on the council. Project how, when we are actually seeing the budgets being cut back every year, money becoming less in the system, how is the rest of the system, rather than just talking about it, going to help us provide it?
Amanda, would you mind just going to slide 42? Just keep going up. Stop. Thank you. I just wanted to remind people of this diagram that's in there, and to say you're right. We've got two processes going on here. The integrated care partnership is the function that is responsible for oversighting the integrated care strategy element of this, and that's because it is a full system, and it's important to recognise not just the traditional health components of that. We've tried to hold good within this of keep going back to what have been considered the 4 key strategic purposes of an integrated care system. And you'll see on there, yes, we've got population health, yes, we've got tackling health inequalities, but we've also got that issue about supporting broader social and economic development, as well as obviously the financial aspects across the whole system, productivity and value for money. So we know that within those broader social and economic factors, housing will definitely focus within that. I don't know, Liz, if you want to make any comments about the housing aspect.
Yes, just indeed. I mean, in terms of the health inequalities, more detailed slide later on, Derek, it does refer to the tackling the wider determinants of health, homelessness, healthy homes, poverty and cost of living, positive work and employment. So absolutely, I would say, all those wider determinants are important, including a healthy home. In terms of the priorities, we've just highlighted 2 of those for things that we need to do here and now in terms of getting some traction on. But rest assured that housing is part of the wider determinants that we've put in terms of the inequalities priorities.
Okay, Heather, just to roll around.
Several things when you've got a pen. First of all, when you put diagrams or whatever slides on these things, could you please include a key? Because there's some really nice pictures of Shropshire with lots of colours on, and I have no idea what they mean.
Okay.
And that's happened in the past. The other, I mean, I read this 2 or 3 times, and there's lots and lots of detail in it, so actually it's quite easy to miss things. And I'm sure housing is included in this, but actually it needs to be really explicit, because it isn't really explicit from this, and it is a fundamental to health and education. So I'd like to see that clearer. I would also like to see that you have had shared with you some slides that came to our HASC last Monday, which showed a number of different things across the county, the inequalities. They showed concentration things. I've written a few things down here. The concentration of the elderly, need requirements of all sorts, but also it ought to look at the cost of housing across Shropshire because it does vary quite considerably across the whole county. So I think those all need to be built into this so that it actually gives you a really good feel for where we have problems of inequalities across the whole county, and it does vary quite considerably. Slide 9 is the one where really that adult social care data and all of those things needs to be included, because you've got those maps there of all sorts of things which I don't know what they were. When you talk about local communities and really working with local communities, how do you define a local community? Because it's easy to use, but actually we need to know, and quite often for many of us in the south, you think the local community is Ludlow. It is not. In the north, you might think that the local community is Oswestry. It is not. So actually, how are we going to break those things down? Because they're really quite significantly different. I was really interested to see the Health and Wellbeing Board from Telford and Ricky mentioned pockets of rural deprivation and so on, whereas the Shropshire one doesn't. Which, anyway, I just felt personally affronted. So I'd like to see that on, and actually one of those slides at the bottom was cut off, so I did wonder whether it was on there and it disappeared. We don't mention pharmacy in this at all, which is now beginning to be part of primary care and primary delivery. And when we've looked at the hub in Shrewsbury, we've got all sorts of pharmacies put at risk by that. And the government and NHS England are very much looking at pharmacies as being part of that front line and diverting people. So actually we ought to be looking at that across the whole of the integrated care strategy, really. I'm interested that you dropped respiratory from there. I'm interested to see, I obviously it's on data, but when we've have a significant number of people who have asthma, an increasing number because of air quality, because of all sorts of other things. Asthmatics do have quite a fundamental effect on admission to hospital and all of that. COVID was a respiratory disease, so is flu. We have significant fuel poverty across a lot of the county, and that tends to mean that you have significant respiratory disease. And then we get back to mould and poor housing and all the rest of it. So I'm just interested in why that has been dropped off the list. And then I'll come back to my favourite, and I finished at that point, which is, if we need an integrated care system, we do have to work cross-border, because the impact and the pressures on SAF, on our acute hospitals, on a whole number of other things can be influenced quite significantly by that cross-border working. Now, there are lots and lots of services just over the border for many of us. They're actually in community hospitals in Wales, very close to us. We don't have a community hospital other than Bishop's Castle, which has been shut at the moment, apart from the odd other service. But there are significant ones in Welshpool. And why do we put all the pressure centrally on the Royal Shrewsbury when I could have gone and had my breast, my mammogram in Welshpool in Tesco car park? If we start taking, the car park was so full when I had to go to the Royal Shrewsbury for that, I couldn't park legally anywhere to have my mammogram. And I wasn't going to give up the mammogram, so I took a risk of parking illegally. Now, I shouldn't have had to do that. Had I gone to Tesco's car park in Welshpool, which is 7 miles away, much better for the environment, and you do talk about the environment in this whole care strategy. There's all of those things that we need to build into this. And because the JSA has done quite a bit of work in my division, and I know you are going to be using it because you've actually built into this, and I said to them, could you go to Montgomery Surgery just to find out how many Shropshire patients they have? They had 236 just at Montgomery. So it's a significant issue all the way along the border that we just need to build into the whole of the ICS because it's a fundamental part of it. Finished.
Well, that wraps it up. Shouldn't be any more questions.
No, there are. I won't give answers to some of that.
Dag, you were next.
Thank
No,
you.
no, I'd like some answers.
Yeah, we'll put Dag in as well.
Okay. Right. Thank you. There are, as you can imagine, few bits and pieces. I should say, Nicola, I should have said last time that I am well aware, not mine, with your Australian background, my Christian name. I spent 3 years playing scrum half for London Australians. So I'm well aware what my Christian name means in Australia.
Okay.
They made it quite clear to me what it meant. Anyway, nothing to do with anything. Clearly, this is an aspirational document, and you don't get anywhere unless you've got aspirations. It's not the first aspirational document we've seen. Liz will remember, I think Liz will remember the first line of the first strategy from the Telford and Wrekin Primary Care Trust. Remember the first line? It was, we will make Telford the most healthy place in England. Remember that?
Well, I wasn't Telford and Wrekin Primary Care Trust.
Oh, right.
I wasn't part of DAG.
Oh, right. Well,
Before then.
So we've had a string of aspirations, but I say you don't get anywhere without aspirations. I think the positive thing about this document is its use of public health data, and I think that is an improvement from all the other documents that we've seen. But nevertheless, as we referred to earlier on, we're very much a hostage of what's going on elsewhere. National negotiations, national shortages, all the issues that we're well aware of, and also this constant tension in the NHS between central control, central requirements, and local flexibility. And we are well aware of everything around that. But some bits and pieces now. Page 5. I'm fascinated by the word. Sorry, I'm going to go to page 5. Equitably. It says high quality health and care services which are equitably targeted towards people in the greatest need. I'm fascinated to know what equitably targeted means to the greatest need.
That brings me back to
That's the first one. There are a few more like that. Page 14 refers to preventative maternity care. That's not contraception, I presume, is it? It's something about. So if we look at the public document, the public need to understand something of what these things mean. There is quite a lot of reference throughout to mental health. The word dementia doesn't appear.
Good point.
It appears in one place, which is the feedback from people who've said that they want access to walking groups and dementia groups. But I'm surprised that given the population changes that you referred to, that dementia, although it might be included in long-term mental health, etc., but I was thought it should have been separately referred to, really. We've talked about the issues about the inequality of access. Obviously, food, heating, etc. All that comes in terms of cost of living and income. It's income, really. It's income, what people suppose income is. Another thing about the use of terminology, page 35. I think I know what a marmot borough is. I think it refers to Fair Society Healthy Lives report, doesn't it? But the public may not know fully what marmot borough means. So maybe a bit of a clarification there. Everyone's shaking their head. I'm a bit concerned. Page 42. We go to page 42. So says here trying to whistle up on his screen. Page 42. I think the issue about social care and the importance of that is possibly on the left shift type thing. And I felt that was a bit understated. The significance of social care, the impact of the social the problems within social care. And I found that a bit disappointing, particularly under paragraph 3, where it says, this work needs to be further analysed and described in the 5-year plan to ensure, etc., etc. I thought we had enough information now not to have continued to be looking, and now surely we know what the issues are, without having to say that need to further analyse and describe it. I would have thought. Just a quick comment about something that might be useful. Are you aware of the again social care, of the Health Service Journal articles they commissioned in terms of relationship between integrated care systems and social care? There's quite useful stuff there. I thought particularly the second one. That's it, sir. Thank you.
Thank you, Dan. I think we'll let Nicola come back on those two.
So I can remember all of them.
There's a lot of information there.
We can.
You might have to prompt me.
I'm sure they'll prompt you.
And
Mine first, because I've got to go.
okay. So the clinical strategy issue. So we do have within the ICS a clinically led process which has identified those 6 clinical priorities. So that in a sense is what's been handed into this process to accommodate that. That said, of course, you know, as we're starting to move down to place level and we're getting closer to, which is the drive behind all this, of course, is to get closer to communities and be more specific about needs. Obviously, if respiratory care is a leading issue within that community, I think the expectation will be it will be a local priority there. There is a sense, I think, within this consolidation document of trying to understand the big picture for the system, but with recognising that subsidiarity, it is going to be very important to, as I said before, not one set of priorities, not one size fits all. It's got to be localised and appropriate so it meets the needs. So there will be processes built into that. With a similar vein, I think, in terms of the clinical strategy, I know that speaking to my clinical colleagues, within the priorities where they refer to mental health when I've probed, that is definitely a catch-all. Perhaps not what we'd necessarily like to see, but for convenience, that is a catch-all, which does talk to a subset of issues, be it learning disabilities, dementia, that there's a whole kind of range of issues that are sitting under that heading of mental health, that I'm sure that when we get into the specifics, because this is very much the what do we need to look at when we get into the how, and things are becoming more detailed, that clearly lines of work will get pulled out in more detail under all of those. MSK would be another example, huge amounts of stuff in there. Some of it's surgical, some of it's around therapies. These are high level comments that I appreciate don't always talk to some of the detail we might want to get to underneath.
Can I go? Yeah, have you got
Remind me.
So what do you recognise as a local community?
Okay.
Do you want me to Rachel can answer it with the GA and stuff.
So I think thank you for the points and the questions, because I think that's exactly why we wanted to bring a team that clarification. I think it's good to have a different lens, because there's terms like pharmacy, which is included in primary care for us, but that's not explicit. And I think we need to be absolutely explicit. The same with wider determinants of housing, and some of it's buried in the details. But in trying to summarise it, we may have lost. So I think I thank you. It's really helpful. And we will feed this back in the ICP on Wednesday and as we update it. Just on the JSNA, yes. For me, what I should have said at the start was it's an ongoing process. We're constantly updating our JSNA through the information we got. What we presented you with is the most information we've got at the moment. You know that in Shropshire we are committed to looking at a community approach. We've got 18 areas. Even within those areas, we've already had challenge, for example, around Shrewsbury, because it's massive. Some are massive geography-wise, some are massive. And so we will have to break that down, that data, and up below that. So for us, it is that community focus. And we'll keep this up to date as that comes through. Your point about rural is really important. We've captured a lot of it in our inequalities, around rural inequalities, particularly in ISIT, but there's more coming around that, because so that's where it fits in, sorry, to the Health and Wellbeing Board. But there's a lot more coming around that. We're going to be doing a lot more to unpick it. And there's a lot of work going on, not just in Shropshire, but some of our rural West Midlands wide and into Leicester, actually, to do some work around unpicking that. So just to give you kind of that reassurance, I was trying to check that I've picked up. And the other bit for me is the real importance in this, and I think you've said it, it's not, perhaps it hasn't come out strongly enough around the left shift and the communities and, you know, the role around social care, that prevention, all of that work. We've put it in, it's written in there, and we've tried to demonstrate what that actually means. But that's fundamental, because we're trying to do two things in this. One is balance getting the best services for our population, the business as usual, that came through the workshops, alongside these are our priorities, these are the aspirational, what we have to do to change our population. And I think, so it was just to kind of to highlight some of that. We need that aspiration, because that's where you shift resources if we're really going to make a difference. But we have, yeah.
The cross-border working stuff
yes,
is really important in prevention.
Absolutely.
And if you don't do that, you'll have a whole load of Shropshire people who don't go through the right prevention stuff.
Absolutely. Again, I'm sorry, I meant to say that
Yeah.
really, really important point. I think we perhaps need to make that clearer, because we don't work in isolation. Although it's a strategy for our system, we don't work in isolation. Actually, from the West Midlands or even indeed the North West and every. Yeah.
I think Dag made two further points. I'll try to
Yes.
well,
You
you may have not. That we haven't covered. Yeah. Preventative maternity care, it's continuity of care, so it's where you have a more of a one-to-one midwife through your pregnancy, and it's particularly focused at Bain community.
I think I understood it, maybe
but
the public understanding.
exactly. And equity. Thank you for your question on equity. I think I must have planted that one, Dag.
Yeah.
In terms of what that means is actually some communities, it's according to need. So it's actually, you know, and we demonstrated this with Betty and Bob, in terms of some areas have low uptake of a preventative health.
Yeah.
Whether it's immunisation, it could be screening, it could be all sorts of different. And therefore those communities might need a different approach. Not necessarily, it's not necessarily about where the service is located. It might be there's other barriers, language barriers. It might be they're fearful of going into a specific building.
Culture barriers.
Culture barriers. So equity is about targeting according to need. It needs to be needs led, and using the JSNA material is crucial in terms of that.
I was just going to add, I mean, as you said, Liz, one of the things, this strategy is what we want to get to, and it's got to have the hooks in it to pin it, put everything on. And I think that's where this was really key, as Liz said, the learning from COVID was that actually one size doesn't fit all, and we didn't want to lose it. But I think it's very difficult because some of it's buried in simple lines. Actually, what is going to become quite complex, and as a hospital, particularly, you need to really understand that, and the population do, because we want to hold the system to account to make sure we're actually doing what we say. So just that's one of them.
David, you want to?
Yeah, just 1 or 2 questions, if you don't mind. There isn't a virus strategy.
Pandemic.
No, not even pandemic. I mean, you can get epidemics and so on and so forth, and even quite localised problems. So I think you're going to have to put something in about your virus strategy, because we all know we got screwed over the past 2 years, something that, you know, we hadn't anticipated. But now I think from reading the literature, there's a lot of scientists are saying, well, actually, there's going to be a lot more. So you need a virus strategy. Another area I feel it's quite weak on is you actually don't refer to big data, machine learning, and therefore that if you haven't got a strategy to introduce some big data mechanisms that are capturing the data, learning from it using machines, not you guys with a little pocket calculator sweating till about 12 o'clock at night. You do need to have that strategy. Otherwise, you will not become a learning organisation. On maybe paraphrasing a little bit about what Heather's just said, I think at some stage you're going to have geographical strategies. So you could have an urban strategy, you could have a small town strategy, and lo and behold, you could even have a rural strategy, but that should come last. Is that right, Heather?
No.
That should come first.
Shouldn't rise.
But see,
I will say,
Don't rise.
they should all be
all be equal. Well, fair enough. But I think you've already said this. I think Liz has said this. That different parts of Shropshire have different needs, different attitudes, different geographies, etc., etc.
Which is where the social care
Yeah.
data really
Yeah.
fits.
So at some stage, maybe not in this document, but certainly for your March document, I think it would be wise to have some words about what the strategy is according to the kind of community that you're talking about. You also need a primary care strategy. I mean, I think we've touched on this once already today, but the reality is nobody around this table or for a long time has looked at what's going on in primary care. What are their performance figures like? I did circulate some performance figures about telephone, which primary care network had the best and the worst telephone access. So that is a separate piece of work, but does need to be recorded that there will be, or this is the strategy for developing primary care. The other one is, I don't know whether this is right or wrong, actually, you'd have to have a debate, but you haven't got a hospital without walls strategy as such. It's scattered around, but it isn't there. And in particular, bearing in mind that the government expect 250 virtual beds by December 2024, i.e. in a year's time, ha, 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 that particular development will have a major, or could have a major impact on a lot of stuff that's done in hospital, or in actual fact on preventing stuff going into hospital. So I think that's another area that you really ought to put some words in. The other one that I would be interested in seeing is what's your formula that you will use for your investments. And that is a very tricky one, if I'm perfectly honest. I'm not talking about the national formula. I'm talking about a local formula, which says, well, what do we concentrate on? Kids, certain diseases, certain areas. I think you do need to sort of flag up there will be a formula, and that would help us actually, because we could then judge against your strategy in terms of the formula that you produce. Or the other one is, we always talk about Shropshire Council and Telford and Wrekin Council. When I worked, which wasn't very often, but when I did work, I always saw Telford, North East Shropshire and South East Shropshire as being my responsibility as the boss of the Princess Royal. And one of the mistakes that are continuously made is it's seen on a local government basis, but actually a true picture of what's going on really has to be presented in terms of East and West, in my opinion, and I would like to consider that. Sorry, I'll now turn on to the next page. Page 46, productivity and value for money. Well, all I would say in terms of what I will be looking for, the acid test will be the percentage of change in your investment profile. Now, you've got the chairman of the, what's it called, ICB, giving out at the last meeting that he wanted to see quite a big shift over from feeding the beast, we all know who the beast is, i.e. the acute sector, and moving resources. And that, I fully agree with the man on this one, And I will be looking at where is the investment going. I'm not calling it cost, I'm calling it an investment. And I think that needs to be addressed in the document. The other one is you've got a lot of, we will do this, we will do that. Yeah, my backside, I want some numbers. If you say we're going to do X, I want a percentage number or a full number. Says if we're going to do X, it'll be this, so that you can be held to account by the public and by this committee. You haven't done enough on direct access testing and your strategy for that and what that means. And I'll shut up. Thanks very much.
Can I just say, I've looked at my diary. My JNSA starts at 3:30, despite it being in my diary for 3. So you've got me a bit longer.
Hooray!
The traffic's awful. Nicola, come
Yeah,
back.
try to tackle some of that. Thank you so much. Really useful feedback, and that's why we're here. Of course, I thought this might be helpful to just refresh for everybody the steps that we're going through, just in terms of breaking it down and how the bits, come together. So one of the benefits, I guess, once the integrated care partnership was set up, it has that responsibility then of driving the integrated care strategy. Now, one of the benefits I think we've had in this system is under the ICP, myself, Rachel, Liz, coming together to really tackle this ICS document as a joint piece of work right from the beginning, to get ourselves on the same mindset, the same language, the same priorities. So when we start to move through to what then becomes the ICB's responsibility, my personal responsibility of writing the 5-year plan, we've already pulled in a great deal of influence from what we understand from local authority colleagues. That's been a great thing. In simple terms, what we're kind of really seeing is the ICS document is really the broad needs assessment. What are the issues that we need to address? And then we go into the 5-year forward view bit, which is how we want to do it. And so working behind the scenes on that, or we've, I can't rustle up and say, here's what we've done earlier, but we've already got a fair bit of work and writing around some of those enabling pieces. So what is our digital IT strategy? What do we need to do about workforce? What's our BI data work, as you've raised there, David, the primary care agenda, the further detail that will come out of MCAP for that left shift. So we know that there's quite some meaty chapters that we've got to get into quite quickly, because all those enabling bits are really fundamental to the how we bring this aspiration to life. And we'll be continuing to work on that jointly, as well as these two documents move from being interim to kind of going through that engagement process. We talked a bit about taking that work down more to local levels. So we know that from the 5-year forward view, there will be that delegation of responsibility down to the place-based boards, and that the place-based boards will be working with the health and wellbeing boards in those areas to shape how do we take the big picture, but also tackle that subsidiarity and make sure that the local factors, be that around rurality, be that around a different picture of what the service needs are, or what the health data is telling us, that we can tackle those at the local level. And as we know, feeding that back up through the health and wellbeing boards brings the local scrutiny picture back to play, and then obviously feeding back into the integrated care partnership. So we're somewhat on a journey at the moment in kind of flushing these out in year one, and I think you can appreciate why therefore we're talking about quite a lot of interim documents, as this kind of comes to be a full circle. David.
Doug first.
One thing I missed, sorry, looking at the inequality section, I'm not sure whether it should be specifically identified, but you need to be well aware, well, I'm sure you are, of the problems of digital exclusion, particularly older people, people with learning disability, people from other cultures, people with mental illness.
Yeah.
And which could be a key, could be a growing problem.
Yes, absolutely. I think you're right.
Can I just give an example and say what would happen? some time ago, earlier this year, I looked at the disease profile of Ludlow, just for a laugh. I was a bit bored that day, so I'll have a look at the disease profile for Ludlow. And what I discovered was there's a lot of kidney disease in Ludlow. Now, let's pretend that you come up with that. Oh, there's a lot of it. Who's actually responsible for making the plan to sort that out?
Nice and featureless.
Apart from Heather.
Thank you.
So from an identification point of view, it would work through this ICS and 5-year planning process, wouldn't it? But behind this has got to be that commissioning plan. And what we need to do with this when we've got it together is understand then we've talked about money, we've talked about the challenges, we've talked about, how do we actually ultimately come to a decision of what we can do and what we can't do, and that's the strategic commissioning intent. So on looking at all of that, I think the question would have to be, in discussion with the place-based boards where things will be delegated to, for your area in this place, we have a pocket of money, we need to fund and buy services. That's where some of that discussion would need to happen at local level. So it's not all happening up here. No, you've raised the challenge. We know we've got a renal issue. It's then working with the place-based boards on the commissioning agenda. How do we address that?
And does that include the consultants who are meant to deliver that service?
What do you mean, sorry?
Well, there are consultants who specialise in kidney disease.
Yeah.
At RSH. In fact, I think the guy looks across 2 sides. So would that individual be involved in that discussion?
Well, they'd have to, and then the service model would have to be clear. What are we talking about? What are the renal issues? Is the commissioning plan for the need in that area? Is it appropriate that we're looking at patients going into an acute facility? Are there services that can be provided more locally? What is that best model of care? Where does digital play into that? What's the workforce implications of being able to bring it to bear? So there's quite a lot in that conversation.
So are you offering customised plans for different areas?
To some extent. But of course, there's going to be limitations for all of us, I think, when we go through the prioritisation process. We look at needs, we look at what's available, to have to come to that collective discussion as to, well, what, where are we going to put our push? And I think what this system is showing is that's not all going to happen in a centralised way moving forward. As we get into this cycle, there's going to have to be delegated commissioning responsibilities down to our place-based boards. So that's where a lot of that discussion will happen.
Rachel.
Yeah, I think I think you make an important point around some of these, because some of this work is, although it may not be specifically in the strategy, these are big areas that we need to come together on. There's business as usual, there's work happening in the background that will continue. So you mentioned health protection. We have absolutely have not forgotten about viruses, health protection, because all that work is for. In fact, we've got a new strategy around the health protection strategy that we've launched based on the learning from COVID across Shropshire, Health and Wrekin. And there's a huge lots of plans in. What we need to do is make sure this references, I think, some of the others, and that links into what we're going to do, how we're going to deliver it. And I think that's where it become more explicit. So some of that is to give you reassurance that is happening, and like kidney disease and others, that work will continue. Where some of it needs to be done at a system level, and as a system-wide priority, it's in this plan. You're right, there'll be other local priorities, and I'm talking about the example from Shropshire, but that's part of the reason we went to place-based, because there might be different issues within different geographies that are very, very local, but actually won't make it to the health and care. They're not really health and care issues. There might be some of the wider determinants. It might be key worker housing or whatever. Some of those may become bigger issues at a county-wide, sort of local authority-wide, or even beyond that, regional. And it's as we work through all of that to understand whose priorities sit where, what can be done locally. But I guess we need to give the reassurance through this as well that that's happening. And I think the detail will come in there, what we're doing, the how we're doing it. But I think I was just drawing myself a diagram here. It might be useful for us to put something in here to show where primary care strategy will sit in this and where some of the others in the detail. Or I'll certainly link that into the. Going to get the joint forward plan.
Yes, yeah, and the JFB, I think, is intended to be also a signposting document for the information itself, but where to go to find more detail on specific we have so many strategies. Part of the challenge, isn't it, is to make sure they are integrated in a way that makes sense.
The
We don't lose
wiring
track of
diagram
things.
does look very complex.
Yes.
On that point, at the meeting, the board meeting of SAF recently, they approved a strategic plan. I've read it. It's wonderful. There are some holes in it. Where does that strategic plan fit in with this?
That's a good question. So last week, we held what is now the first integrated strategy committee as a subcommittee of the ICB. The key strategy leads from South, from Shropshire, Robert Jones, etc., as well as actually Liz and Rachel will be joining that group. So we are being able to keep an oversight. It's a little bit potentially like chasing cats, isn't it? We want to kind of make sure they're all going on the same path. So we will start to have oversight of individual organisations' strategic plans within that framework. What we'll also do, the MCAT work will be a good, I guess, first example of that, is taking that type of information into that committee with all of the strategy leads. So as we're co-designing, it's having everybody at the table, everybody who's responsible for strategic planning in their key organisations being around the table. So as we're shaping this planning process going forward, that they're all there at the table.
Who gets the output of the MCAT? Is that given to the public? Is it given to us? Or is it just kept within your own organisation?
So well, it's a question of who's going to be able to understand key parts of it, isn't there? The granularity detail in the collection process is going to actually be huge. But what we've agreed, and all provider organisations are part of this process. So both sites of SAF, Shropshire, Robert Jones, you know, this isn't just a one hospital, it's a full system for us in STW.
That describes the NHS elite. I'm talking about the rest of the population.
Okay, well, give me a second. So within that, obviously we will have the top level of amalgamated data. What it will do is give the system picture. Underneath that, if you like, almost by sub-chapters, we'll then go into SAF, full picture for SAF, and underneath SAF, individual facilities. Shropshire, overall picture for Shropshire, some of our individual community hospitals. So it will be aggregated so that it can support very local developments, but it can also be wrapped up with that big picture.
So when can I get my hands on it then?
Well, I think we agreed, didn't we, of an offline discussion pretty close in the new year to look at the first cut of that data, because my intention with that as a co-design piece is that we can start to see the full continuum of our services across STW and where we might want to support the left shift and where we might want to see some of that.
That'd be good. I think let's go into IC board next, was it?
This is going to the Integrated Care Partnership.
Partnership, sorry, wrong one. Wrong initial.
Later this week, myself, Rachel and Liz will be there, so we will be taking.
I guess you'll be
the same
updating this
presentation.
before that goes then. Reflecting a few comments from today.
Actually, somewhat the other way around, because this is running as it's almost a live document that's being updated all the time. Technically, the ICP signs off the consolidated work that we put together from the two health and wellbeing boards. What then happens is that comes out to consultation, and that's when we'll formally start to continue to tweak, amend, and shape the document. So it's a question of, with both committee meetings this week, we didn't want to miss the opportunity of being able to share that with you today, but all the comments for today will move as part of the engagement process into this document.
Well, thank you for that, Nicola, and wish you well with the various iterations of this evolving document. And no doubt it'll come up in our meeting. We've got an informal meeting in the planning already, so I think we've given it a good go today, to be fair, and I think you've got a lot of information to go with, so thank you. Right.
I think the action planning underneath it will be the fascinating thing.
Yeah. Item 6, co-chairs update. Did my two Ronnie's bits, there's nothing from me.
And there's nothing from me.
That's forever. Item, well, it's not actually on the agenda, but work programme. Tom?
Okay, so I think we may have rehearsed this already from the work programme, but it's useful for me to just hear back from the committee members as well. Following the previous meeting of the committee, I think the chairs shared a view on how they might like to take forward the work of the committee to a stronger focus on fewer, more substantial topics and use the offline briefings approach to and workshops and sessions of the committee to be able to review the data, review the information, speak to different people, find out more in maybe a more informal situation. And as we sort of mentioned earlier about maybe heading towards a summer session focused on urgent emergency care and some of the learning from the Shropshire Task and Finish group would be a similar model. So I think from a work programming perspective, I would suggest that we have a session on the 23rd of January of this committee. So that's follow-up on the Ockenden paper, which came at the beginning of November, and primarily a focus, I think, on the learning and the impact and progress around the staffing that they shared at that meeting. Following that, it might be worth us having a bit more of a work programming discussion. For me, certainly from a Shropshire perspective, it's really valuable to have conversations with the committees I work with to go through a topic and be able to scope that out more completely with them. So it wouldn't necessarily be we hold it in a public session, but we're able to work through and be clear about what the outcomes are you want to achieve, what the impact is you expect to achieve through that piece of focus and work, but also what information you think you want to have. So we as officers can start sort of hunting that down, making sure that we've got the right people lined up, but also who you might want to hear from as well. So it's just that focus, I think, is a chance for us to do, Sam and I discussed this earlier, like a midterm review of the work programme, and we can bring that into focus. I think also, I'll catch up with Sam and Stacey after this, but it's a chance for us to start to plan in the sessions, as Nick was just alluded to there. Good chance for us to get that first online session for all of you as members of the committee and all the co-optees to be and receive the first sort of set of data and the first conversation about what's happening next and what are we learning. So I think the MCAP would be maybe one of the first bits on the table, but where do we go next and how do we start to follow up on what's happening?
Good, thank you.
Doug.
Yeah, I think the two health watch organisations are required to produce their annual report, aren't they?
Yeah.
I don't know if we've ever received the annual reports, but clearly that should be something we should, whether we do it informally or in what way we do it, we should see that and hear what the health watch organisations feel are the key issues in health and social care across the county, shouldn't we?
Well, it's really useful because we've got to have two senior members of the Health Watch on here.
Yeah, we
have them.
Yeah.
But they will be able to feedback. But I think we normally get it sent through an email, but it's never part of the agenda.
Yeah.
Okay, so I think that concludes this year's meetings. That just leaves me to wish you all a happy Christmas.
Yes, and can I wish you the same?
Yeah.